Rumman, please come to the screen, introduce yourself and present your case. Just a case summary. Okay, Rumman, can you hear me?
Yes, sir. Yes, sir. Assalamu alaikum, my honorable and respected teachers. I am Dr. Rumman Khondokar, FCPS Part 2 course student in Bangabandhu Medical University. My patient, Mrs. Rashida Begum, 35 years old lady, presented with gradually increasing pain and slump in her left breast for the last 2 months. She had no features of metastasis. She is non-smoker and non-alcoholic and has no comorbidities. She has no family history of breast cancer, ovarian cancer, colon or any other cancer. She also have no history of any previous radiation exposure. Her menstruation cycle is regular and the menarche started at the age of 12 years. She is a mother of 2 child and was delivered by lower segment cesarean section, and both of them were well breastfed. She had her first child at her 20 years of age. On general survey, and all her vitals were within the normal parameter, and her Eastern Cooperation Oncological Group performance status oncology was 1, and her body mass index is 27. On the examination of her breast, her both breasts were symmetrical and bell shaped. It was moderate in size and measured C cup. Bilateral grade 3 ptosis present in the both nipples. And other findings of the right breast is normal, but in the left breast, there is a lump in the upper and outer quadrant of the breast, which was in the 2 to 3 o'clock position and 3 centimeter away from the nipple and areola complex. The lump is about 2 to 3 centimeter, 2 into 3 centimeter in size, hard in consistency, which was irregular, and margin was ill-defined. But it is not fixed with the skin or chest wall. There is no nipple retraction or nipple discharge, no palpable lymph nodes in both axilla, and left supraclavicular lymph node is also not palpable. On abdominal examination, there is a healthy fenestrial scar mark present, no organomegaly, no ascites or any nodule in the umbilicus. Digital rectal examination also normal, and other systemic examination reveals no abnormality. So my clinical diagnosis is carcinoma of the left breast, and my clinical staging is T2, N0, and MX.
Thank you, Dr. Ramman, for presenting your case. Professor Modit, sir, can you hear me, sir?
Yes, this is all right. Her presentation is all right.
Okay, thank you, sir. Thank you. Professor Rahana.
Yes, presentation was very nice.
Comment. Okay, then. And finally, yeah, Dr. Jakarullah.
Absolutely fine. Everything is included correctly. Absolutely fine.
Okay. So now you can ask the question to Dr. Rumman. So over the next 15 minutes, আমরা এই কয়টা part নিয়ে আলোচনা করব about this case summary, the rationality of the diagnosis, the investigation, and the treatment. So now you can proceed with the question to Dr. Rumman. Rumman,
Yes.
What do you want to do now?
Sir, I want to sir, complete my triple assessment, sir, by doing some investigations.
What?
Sir, first I want to do mammogram of the both breast, and then sir, ultrasonography of the breast and both breast and axilla with ultrasound guided core cut from the suspected lump I have found.
Okay. তুমি যেটা বললা, first investigation you will do a mammogram, and then you will do an ultrasonogram of both breast and axilla, and you will do a core cut biopsy. So,
Yes.
Professor, will you make any comment on it? The first investigations.
Yes, the imaging is the first investigation, but if she says ultrasonogram first, that will be more rational than the mammogram.
Than the mammogram, and that will be supplemented by the
Oh.
mammogram.
But as she is going for the TrueCut biopsy, okay. So he can attend the mammogram first, even because once ultrasonogram is done, and with the core cut biopsy, the mammogram will have an distorted architecture.
Yes, yes. But what is done really, in practical scenario for this patient, a ultrasonogram, and this was the report of the ultrasonogram. It's a fibrocystic disease, axillary lymphadenopathy, and a swelling in the left breast, as দেখতে পাচ্ছি আমরা. So are you happy with the report, Dr. Roman?
Sir, in the ultrasonography picture of the lump, sir, it seems to be irregular shape, sir. Sir, the report is not
Irregular shape. Are কিছু আছে?
yes, sir. It is sir mixed echogenicity, and sir, wider, sir. So rounded shape টা sir distorted, sir.
মানে কোনটা থাকে ইউজুয়ালি কি মানে বেনাইন গুলোতে তোমার মানে হরাইজন্টাল আর ভার্টিক্যাল কোনটা বেশি থাকে ইউজুয়ালি?
Sir, usually sir wider horizontal টা বেশি থাকে, sir.
তো মার্জিন ইজ ইররেগুলার।
জি স্যার, ইরেগুলার।
এখানে ক্লিয়ারলি দেখা যাচ্ছে তোমার ক্লিয়ার মানে ক্লিনিক্যাল
Yes, sir.
সাসপিশন সোনোগ্রাফিক সাসপিশনটা হচ্ছে এই তো?
জি স্যার।
ওকে।
And sir, Byred's is also not mentioned here.
Byred's is not mentioned here. That's a very important thing. Okay. So রিপোর্টে তাহলে কিছু কিছু রিপোর্ট মানে আমি স্টুডেন্টদেরকে বলবো বা এদের যা আমরা যাদের সঙ্গে যেগুলো আল্ট্রাসাউন্ড রিপোর্ট পাই বা ফ্রিকোয়েন্ট যাদের সঙ্গে কাজ করি এইগুলো একটু বলে একটু তবে যে রিপোর্টিং সিস্টেমটা মানে যেন একটা ফরমেটেড হয়, যে কোনো একটা গাইডলাইনের মধ্যে হয়, কারণ এগুলো হলে তাদের সঙ্গে আমাদের গ্যাপটা কিন্তু বেড়ে যাবে। সো বাইরের সিস্টেমটা আমাদেরকে এখানে ক্লিয়ারলি উল্লেখ করতে হবে। ডক্টর জাকিরুল্লাহ, will you make any comment on it?
Absolutely brilliant. I think সবচেয়ে প্রথম যেটা বলতে হয় সেটা হচ্ছে ট্রিপল অ্যাসেসমেন্ট। যে কোনো ইনভেস্টিগেশন করার আগে আমরা যেটা কি কথা বললাম ট্রিপল অ্যাসেসমেন্ট, এন্ড দ্যাট কনসিস্ট অফ ক্লিনিক্যাল অ্যাসেসমেন্ট। ক্লিনিক্যালি কিন্তু আমরা বলি P1, P2, P3, P4, P5. I'm not sure whether you heard about that. P1 means completely normal breast. P2 is maybe something benign, clinically feels like benign, maybe a solid lump, very well margins, there is not fixity, mobile, like fibroadenoma, we call P2. P3 is indeterminate when we don't understand whether this is slightly irregular, slightly solid, cystic. P4 is suspicious for cancer. P stands for palpation. And P5 is definitely cancer. So your clinical assessment is number one. Your clinical assessment, if it is P4, P5, then you'll be suspicious. Second thing is, yes, she's 35 years of age. Ryan is absolutely correct. Shumi is absolutely correct. Because at 35, normally we say mammogram is indicated after the age of 40 or above 40. So, just the 35, আমরা the first line হিসাবে একটা ultrasound করতে পারি. But Azad Bhai is completely correct. Look at the picture rather than actually going through the result, because sometimes ultrasonographer might not be absolutely an expert in breast imaging. They're doing ultrasound scan, but you have to have a dedicated ultrasonographer who is just doing ultrasound scan for breast all the time. So here they're saying fibrocystic disease, but I can't see fibrocystic disease here. If you compare the fibrocystic disease, you will see cystic and solid component with irregular with some sort of what you call not irregular margins, but definitely no obvious solid area to see. In this particular area, you can clearly see a solid structure, some acoustic shadows going down as well, and irregular margin. Of course, that will be very suspicious. I would probably say U3 or U4, which is again suspicious. If you don't say U5, which is again same thing, U5 means cancer, U1 is normal, U2 is benign, U3 is indeterminate, U4. Exactly the same way. Radiologically, we say R1, R2, R3, or M1, M2, M3, এভাবে বলা হয়. A Byred's classification is very important. There are two ways of Byred's. One is about the density of the breast. They categorize 1, 2, 3, 4, 5, and also the density or the thickness or the structure. Byred's 1, 2, 3, 4, 5, 6 as well of the cancer. So that is very important. So in this particular case, ultrasound to start with, but of course, we'll do a mammogram as well because you're suspicious clinically. Okay.
Okay, thank you, Doctor, for nicely demonstrating these sonographic and the clinical grading and grading. So এখন in real scenario তে এই পেশেন্টের যেটা করা হয়েছিল followed by a FNSA. Dr. Rumman, what is your opinion? FNSA is fibrocystic disease.
Yes.
Will you advise your patient for an FNSA?
Sir. No, sir. Sir, I want to do core cut biopsy, sir.
Cut biopsy. Okay. In real scenario, following this ultrasonogram and the FNSA report, patient was advised for a wide local excision. Do you agree?
No, sir. Sir, my triple clinical suspicion is malignancy and triple assessment is not completed yet. So I want to, sir, investigate further.
No, triple assessment তো যিনি মানে অ্যাডভাইসটা করেছেন উনি তো ক্লিনিক্যালি দেখেছেন, উনি তো একটা ইমেজিং আল্ট্রাসাউন্ড করেছেন, উনি তো একটা এফএনএসি করেছেন, তো ট্রিপল অ্যাসেসমেন্টের তিনটা অ্যাসেসমেন্ট তো হলো।
Yes. Sir, FNSC may be give false results sometimes. So I want to go for core cut biopsy, sir.
You will advise FNSA?
Before.
You will advise FNSA?
No, sir.
No. So this is an important message to all the students. আমরা এরকম বারবার কিন্তু ক্লাসে বারবার রিপিটেডলি বলছি যে এফএনএসি এই ব্রেস্ট লাম্পের এই ধরনের ক্ষেত্রে there is no role of FNSA. প্রফেসর রায়না?
Yes, sir. That is very true. There is no role of FNSC in any kind of breast pathology.
Breast pathology. This is a very important message. আজকে স্টুডেন্ট আমাদের যারা আছেন এখানে অনেক স্টুডেন্ট আছে, দুদিন পরে সার্জন হয়ে যাবে, অতএব এই জিনিসটা মাথার মধ্যে রেখে প্র্যাকটিক্যাল লাইফে কিন্তু ইমপ্লিমেন্ট করতে হবে যে নো রোল অফ এফএনএসি। সো হোয়াট ইজ দ্য নেক্সট অ্যাপ্রোপ্রিয়েট ইনভেস্টিগেশনস, যেটা আমাদের সে বললো যে আমরা ওই কোর কাট করার আগে ডেফিনেটলি you should have this mammogram, and mammogram revealed there is a lesion approximately 3.5 to 3 centimeter and a BIRATS 4. Okay.
Yes.
You see the lesion? Can you see the lesion?
Yes, sir. I can see the lesions.
Okay then.
Sir,
Then what?
Sir, then, sir, I want to do sir ultrasound guided core cut biopsies from the lesion.
Mammogramটা কেন অ্যাডভাইস করলে? Why mammogram?
Sir, yes. Sir, it can, sir, I can see the characteristic of the lump with it has speculation, and other also can see the opposite breast, and we especially in microcalcification, and we can see in the mammogram which cannot be seen in the ultrasonography.
Yes. একটা হচ্ছে calcification. Another
Yes.
thing?
Sir, in mediolateral oblique view, lymph node also can be seen.
Can be seen. আর কিছু আর কোনো কারণে?
Sir, and sir, breast architecture and tissue plate গুলা sir আমি দেখতে পারবো sir mammograms.
অপোজিট ব্রেস্টটাকে দেখতে
জি স্যার, অপোজিট ব্রেস্টের কোনো লেশন আছে কিনা স্যার, অথবা
মাল্টি ফোকাল মাল্টিসেন্ট্রিক
Yes, sir.
মাল্টি
Yes, sir.
এগুলো আমরা
Sir,
দেখতে পারি। আর কিছু অ্যাড করবেন ডক্টর জাকিরুল্লাহ?
খুব সুন্দরভাবে বলেছো তুমি, অ্যাবসলিউটলি ফাইন রোমান, বাট মেইন থিং ম্যামোগ্রাম আমরা বলেছি যে 40-এর বাইরে আমরা মানে আরম্ভ করি না, বাট this particular patient was suspicious from clinical point of view, so mammogram can be done at the age of 30-35 as well. So as a baseline mammogram we always do that. এখানে দুইটা ভিউ দেখা যাচ্ছে, একটা CC view, একটা MLO view. I'm sure those are actually students you already know. The CC view you'll see just like a half moon, যেটা রাইট সাইডে আমরা দেখতে পাচ্ছি, আর MLO view যেখানে তুমি pectoralis major muscle-টা দেখতে পাবে, but a mediolateral oblique view. Very interestingly, left-sided breast we can see in the CC view that is basically laterally the lump is there, and
Yes.
in case of MLO view superiorly the lump is there. So it's an upper outer quadrant the lump is. So you can actually identify whether there's any other lesions, যেটা আজাদ ভাই বললেন. At the same time, irregularity, asymmetry, calcifications, or any sort of irregular areas or other, and also abnormality with the duct and other thing can be visualized by mammogram. Having said that, this breast looks a bit dense breast কারণ উনি 35 years of age. এই ক্ষেত্রে অনেক সময় আমরা যদি দরকার পড়ে যদি radiologist মনে করে it's not very clear, you can add some MRI as well. We'll talk about that later on. But I think that is the main reason you have to remember mammogram and ultrasound is mammogram everybody can see. Ultrasound is person dependent. The person who is doing it, he or she only knows what he is or she is seeing. So you know, my mammogram is much better, and sensitivity for mammogram alone is about 60 to 70% or 75%. Ultrasound added on another 20%. So altogether, it will be about 95% sensitive test combining these two as a part of triple assessment.
Okay, then thank you. Dr. Rupa আছে নাকি? Dr. Rupa?
স্যার পাচ্ছি না আমাকে।
আচ্ছা, ওকে থাক, ঠিক আছে, মানে তাকে আমাদের আরো পরে লাগবে বেশি। So এরপরে ইনভেস্টিগেশন ডক্টর রোমান যেটা বললো, you will do a core cut biopsy. This is your core cut biopsy report along with the immunohistochemistry. Dr. Roman.
Hello, sir. Sorry, sir. There's a network problem, sir. Sir, can you repeat the question, please, sir?
This is your core cut biopsy report along with the immunohistochemistry. This is infiltrating ductal carcinoma, grade 2, no LVI or no PNI, and immunohistochemistry is that T and BC, and Ki67 is 20%.
Hello.
হ্যাঁ, শুনতে পাচ্ছি।
জি স্যার। Sir, report showing, sir, that it is triple negative breast cancer with high Ki67 index.
So, with this report, what will do now?
As sir, the tumor, sir, showing it is moderately differentiated and triple negative and high Ki67, triple negative breast cancer. It is unfavorable biology, tumor biology. So for the treatment planning, sir, I want to arrange a multidisciplinary team, and we'll plan further, sir.
Okay. Yes, Dr. Zakirullah, you can ask question.
হ্যাঁ, না এটা খুব একটা বলি যেটা আজাদ ভাই বলেছেন, আমি I can repeat again. Please, from now on, I don't want to see anybody is doing final aspiration cytology. Please don't do that. Even a lobular carcinoma, full-blown lobular carcinoma, final aspiration cytology, অনেক সময় দেখা যায় normal cell. So don't do that. Always core biopsy. Okay, that's the most important thing. সবকিছুর জন্য, even lymph node জন্য sometimes core biopsy is better than final aspiration cytology. Now, according to this one, it's a great to investigate ductal carcinoma, which is quite common, but there's no lymphovascular invasion, and also it's a triple negative breast cancer. Ki67 is still done in Bangladesh, but most of the European countries and America, they don't normally do all the time. The reason is Ki67 is very unpredictable because it depends on who is actually doing it, which particular area has been done, and there is no real protocol anywhere internationally about Ki67. So it was initially thought that it's a very good predictor for thinking of this cancer is going to come back, but you'll see that there are more other types of predictor, oncotype DX and other things are coming up. But anyway, Ki6720, it might be depending on where it's actually done, whether they did it from dark area or the light area. So quite a lot of differentiation you'll find out from the latest literature survey as well. So in the UK, we don't do that. That's the main thing for the breast cancer. However, it's some sort of indication. If it is more than 20%, there's high chance of cancer coming back. And then less than 20%, probably not. That's how they normally used to do before. Now, about this ill-defined mass, and then this is the histology. The treatment, we know what the MDM will ask us to do that. So let me hear from students what kind of thought process is going on.
Yes,
Okay.
yes.
Sir.
What is your proposal?
Sir, my plan is, sir, to go for a new after proper staging of the patient and proper counseling. Sir, I would like to go for neoadjuvant chemotherapy. Sir, এর পরে বলবো স্যার।
Yes. Neoadjuvant.
Sir, neoadjuvant chemotherapy followed by definitive surgery. As it is early breast cancer, I want to do breast conservation surgery for my patient, and then and with sentinel lymph node biopsy, and followed by radiotherapy, and then it will be followed by adjuvant chemotherapy. So this is the treatment plan for my patients.
Okay. Can I ask you one thing? Sorry, Azad Bhai.
Yes,
I mean, if it was not a triple negative cancer, what would have been your choice of treatment? Because if it was grade 2, invasive ductal carcinoma, but ER positive and HER2 negative, just to understand so that you can think about differently as well. It's a triple negative, that's why I'm thinking that you're giving some chemotherapy. But if it is ER positive cancer, what would be the choice of your treatment?
Sir, ER positive and HER2 negative, sir, it in molecular subtype, it will be in the luminal A group. That is a low risk tumor. Sir, so we can go for sir, breast conservation surgery followed by radiotherapy in these patients.
Okay, but she's a young lady.
And sir, also hormone therapy, as hormone therapy is an option as the ER receptor is positive.
Okay, I don't confine, but I think if it is grade 2 invasive cancer, 35 years of age, and the lymph node is negative, and grade 2, would you do anything at all? It's just going slightly higher because you're answering very good. That's why I'm just thinking your thought process.
Sir.
Would you do anything at all? Does she need any chemotherapy? Would she need any chemotherapy?
Sir, I'm great.
Grade 2, invasive ductal carcinoma.
Sir, yes, sir. Sir, invasive and more size is more than, sir, 2 centimeter, or more size is up to 3 centimeters. So there is a role of neoadjuvant chemotherapy by downsizing the tumor. Yes, sir.
Okay. Yeah. Okay.
Yes, sir, downsizing the tumor, sir, it can facilitate the breast conserving surgery with negative clear margins.
Okay. I don't want to confuse you anymore. Normally, ER positive cancer and HER2 negative cancer, grade 2, that kind of cancer, no lymph node involvement, neoadjuvant chemotherapy has got very, very, very minimum role.
Yes.
It doesn't work.
Yes.
So what we normally do in Western countries everywhere, we take the cancer out and then send them for oncotype DX. It means we send the tissue to see whether they'll really benefit of chemotherapy. But for triple negative cancer, you're absolutely right. Triple negative cancer patients get benefit out of neoadjuvant chemotherapy because we want to see the total response. Almost 40 to 50% of the patients can have complete pathological response. That's why for this particular patient, your answer is absolutely correct. Is it okay with everybody? Because 148 candidates are there, I can see. I'm not confusing you, am I?
No, sure.
No, sir.
Dr. Ruman, can you tell me what type of regime you will use for this patient?
Sir,
total cycle of chemotherapy.
Yes, sir. I want to use, sir, taxane and anthracycline based chemotherapy. It works good in triple negative breast cancer. Hello.
হ্যাঁ, শুনতে পাচ্ছি। Okay, how many cycles you will give this year to this patient with this triple negative breast cancer neoadjuvant chemotherapy?
Yes, sir. Sir, 8 cycle chemotherapy, sir.
8 cycle. So
Yes.
whole 8 cycle you will give preoperatively.
Sir, after starting my chemotherapy, sir, I will assess the response of the chemotherapy. If it is responding, then I will continue I will give the full course chemotherapy. If not responding, then I will, sir, assess the patient, sir.
This patient,
Hello.
yeah, Dr. Kamal.
Yes.
This patient planned for 8 cycle chemotherapy, followed by plan was a wide local excision, SLNB plus minus ALB. This was the provisional plan. What is your opinion?
Triple negative, there is no option other than going for neoadjuvant chemotherapy. So the neoadjuvant chemotherapy, for any reason, some of the patients sometimes progress. Even then, we change our protocol with platinum. Even there is progression, then only we go on surgery. Otherwise, the rule of thumb is in triple negative, whatever the size is, something more than 1 centimeter. If it is more than 1 centimeter, there is some debate, 2 centimeter, 1 centimeter. Irrespective of nodal status, we need to go for neoadjuvant chemotherapy because there is 2 reasons. One is there is 55 to 60% complete pathological response in triple negative, and if we use immunotherapy, it comes to 65% complete pathological response, and this complete pathological response can be translated to overall survival benefit now as per one meta-analysis. So that's why আমরা এখন বলি যে triple negative there is no option other than going for chemotherapy first, and we finish all the chemotherapy and then we plan for surgery accordingly. But there is no harm of doing wide local excision in triple negative. That was a myth, especially in Bangladesh. The TNBC mastectomy is the solution. That is no more valid. There are so many papers published that triple negative with wide local excision is as safe as luminal A type.
Okay. So patient had a mammography after completion of this 8 cycle chemotherapy. So lump size has reduced from 3.5 to 1.6.
Sir, in this report, my previous lump size was 2 into 3 centimeter, and as mentioned, 3.5 into 3 centimeter, and it is now 1.6 into 1.4. That is nearly 50% reduction of the previous size. So it is according to the RECIST criteria, it is partial response, sir.
Dr. Zakirul Oilum, make any comment?
Right. Slightly differently we do here, because anybody with that particular age group, with that kind of big cancer going for neoadjuvant chemotherapy, of course, mammogram is important, but we do MRI scan, as I mentioned to you. MRI is much more specific, and especially with the dense breast, there might be some other lesions which can get missed. And Bangladesh on MRI. Second thing, I can't see any hydromarker here. Did she have any hydromarker? Because now
No,
you are planning to do wide local excision, but if she had complete pathological response, how do you know which area to take out?
Yes.
Sir,
before, yes.
So there is no hydromarker I can see. Fortunately, unfortunately, a tumor did not regress that much. But you have to think about it. Whenever you do, just think about what is going to happen when it's complete pathological response. How can I find out that area? So hydromarker is important. Yes. MRI is important because we always do 3 MRI at the beginning, halfway through, and also at the end. So this MRI is very important to identify whether there's which area to take out at the same time the response, because mammogram might not show exactly true picture. Sometimes there's some tumor necrosis after chemotherapy that will give that area exactly the same. So MRI is much more specific. So try to do that. So these are my comments. And Kamal খুব সুন্দরভাবে বুঝিয়েছে, beautifully বুঝিয়েছে কি chemotherapy দিতে হয়. Mainly definitely anthracyclic based or তাছাড়া taxane based. If that's not working, then platinum based chemotherapy. And if you get residual tumor, then capecitabine. These are the main thing they normally actually do if there's after taking it out. But of course, there are immunotherapies as well. this is also working in Bangladesh. I'm sure people are using it in Bangladesh as well.
Yeah, Dr. Ruman.
আজাদ
Yes.
ভাই
এখানে
যেটা
কি হয়েছে?
জাকির ভাই যেটা বললেন, the rule of thumb is if we are planning for neoadjuvant chemotherapy, এখন বলাই হয় MRI should be the imaging to see the response. কারণ neither ultrasonogram nor mammogram can give you a real clue যে মানে how sometimes মানে there is some tumor, but whether it is মানে viable or not viable, it can be assessed by MRI. It cannot be assessed by this ultrasonogram or mammogram. There are some limitations. এই জন্যই একসময় বলা হতো ইয়াং মেয়েদের বেলায় শুধু এমআরআই করা হয় ব্রেস্টে। এখন একটা নতুন মানে ইন্ডিকেশন অফ এমআরআই হচ্ছে, যেটা জাকির ভাই বললেন যে প্রি ইন বিটুইন লাস্ট, এটা হচ্ছে অ্যাসেস দ্য রেসপন্স অফ নিওঅ্যাডজুভেন্ট কেমোথেরাপি এমআরআই। সো এটা হচ্ছে মানে ইটস এ ডিফারেন্ট ইনফরমেশন ফর দ্য সার্জন, যে যদি আমরা সত্যি এরকম প্ল্যান করি উই শুড ডু এমআরআই, উই শুড নট স্কিপ এমআরআই।
Thank you, Dr. Kamal. Dr. Ruman, what is
Yes.
the pitfall in management of this patient?
Uh, Sir, yes, sir. Sir, a marker should have been placed before the NSCT started.
Starting the NSCT দেওয়ার আগে একটা মার্কার প্লেসমেন্ট অবশ্যই করতে হবে। It is a rule. Marker should be placed. Okay. So, Dr. Zakirullah, this is I think the major pitfall of this management of this patient. The marker has not been placed into the tumor. But one thing is that, Dr. Zakirullah, can you hear me?
Yes, I can. Yes.
So, marker has not been placed there. There is no marker. And lump is regressed 50%. Still, lump is palpable. So, in this event, to overcome this pitfall or the rescue measure, so at this point, can this lump be removed by placing a guide wire to this lump in imaging, and then BCS can be done?
Yes. Yes. I mean, if the lump is still palpable, then you don't have to put a wire, but you can ask the ultrasonographer to mark the skin. If you're not absolutely sure that the lump you're feeling is a true lump, or this is some sort of bleeding happened or necrosis of the tissue happened, that's why you're feeling a lump. You can ask the ultrasonographer whether this is the same cancer what you've seen before, and do a skin marking so you know exactly which area to go through. Otherwise, if the lump is vaguely palpable or maybe completely non-palpable after putting a hydromarker, then you have to have a wire-guided wire local excision. Nowadays, we use, in the UK and USA, we are not using wire anymore, but in Bangladesh, this is completely appropriate. Just putting a wire at the target area or where the hydromarker is and take that area out. Not the whole area, but at least the center part with the marker clip to take out, so that you can see what kind of response do you have after this chemotherapy. So that's the treatment of choice, definitely. আজাদ ভাই, আর আমি যেটা বললাম এখানে এখন করা হয় না ভাই, এখানে আজকাল করি আমরা যেখানে বলা হয় কতগুলি ডিভাইস আছে, লাইক ম্যাক্সিড, then other devices. We have got a machine which normally locate that particular mag seed where this particular seed is, or sometimes we do hologenic seed. This kind of stuff we are using instead of wire. So the best thing is wire need to be put in day before or on the day of surgery, but mag seed or hologenic seed can be put in 7 days, 20 days, 30 days before. So on the day of surgery, you'll just go and take the lump out. I'll talk about that later on. Program.
Okay, thank you. So this was about this case. আমরা দেখি স্টুডেন্ট থেকে কি মানে কোয়ারিজ গুলো আছে। ডক্টর সাইফুল আর শিউলি একটু বলবেন মানে চ্যাট বক্সে কি আছে কোশ্চেন?
দেখছি স্যার একটু।
হ্যাঁ, চ্যাট বক্সে কি কোশ্চেন আছে?
বেশিরভাগই কমেন্ট। একজন হচ্ছে মিনিং অফ সিকআপ উইথ সিভিয়ার টোসিস, এটা বলতে কি বোঝাচ্ছে?
একটু আমার মনে হয় ভালো ডক্টর জাকিরুল্লাহ।
এটা খুব সুন্দর কোয়েশ্চেন, এটা কিন্তু অঙ্কোপ্লাস্টিক কোয়েশ্চেন। এটা রায়ান আওয়াল ভালো জানতো। আমি বলি সাধারণত ইন জেনারেল আমার মনে হচ্ছিল যে তোমরা সি কাপ বলেছ, আমার কিন্তু দেখে এটাকে ডি কাপ মনে হচ্ছে, but it might be different because I haven't seen this patient myself. What is cup? Cup size can vary from person to person, and it's actually the bra size we normally measure. Just roughly remember, if anybody's when you
পরে
examine
কথা
the
বলেন
breast,
ক্লাসে।
when you examine the breast, if you actually find out the breast volume when you measure, approximately would be around 150 to 200 grams. If you take it out, that is A cup. So B cup is about 300 to 400, just double it. C cup is about 450 to 600. G cup is about, again, same 150, 150, 150, 600 to 800. So that's how we normally measure the cup. But there's some sort of devices. I know that Shumi normally uses something from outside that can tell you the size of the breast. Now, ptosis normally is measured according to the plane of the
কথা
nipple
বলেন।
position. আমি বোধহয় দেখিয়েছিলাম একবার, but I'll definitely show you in future how to identify what kind of ptosis they have got. If the nipple is above the line, inframammary crease থেকে যদি আমরা একটা লাইন ড্র করি, তার above এ যদি থাকে, that's no ptosis. If it is at the line, mild ptosis. If it's below the line, it's as moderate type of ptosis, type 2, type 3. So it's aesthetically, if you are going to do any oncoplastic breast surgery, then it's important. Otherwise, for general breast surgery or breast cancer treatment, ptosis or size of the breast is important so that you don't need to make a mess out of the surgery. That's the main important thing. But I'll send you some pictures to Azad Bhai, and he'll give it to you about the ptosis and how to measure the breast.
Okay, then thank you. Thank you. Professor Rahana, will you make any comment about the management?
Yes, what Jakirullah was saying, yes, about the management. Possibly she has already mentioned about the wide local excision and SNB, and according to the result of SNB to go for LND.
একটু সিগন্যাল আমরা হচ্ছে আমরা শুনতে পাচ্ছি না রেহানা।
আচ্ছা, জি আজাদ ভাই, না ও তো মানে রাইটলি মেনশন করেছে যে হোয়াট ইজ দ্য নেক্সট স্টেপ। নেক্সট স্টেপটা বলেছে ওয়াইড লোকাল এক্সিশন প্লাস এসএলএমডি। দ্যাট ইজ এ রাইট অ্যাপ্রোচ ফর দিস কেস।
ওকে, থ্যাংক ইউ ভেরি মাচ। আমরা তো নেক্সট কেস প্রেজেন্টেশনে যাই। একটু নেক্সট
স্যার একটা কোয়েশ্চন ছিল স্যার।
হ্যাঁ বলো।
Sir, is there any relationship of the development of the breast cancer with the mode of delivery, either normal delivery or a lower uterine cesarean section? Is there any relationship of the development of the breast cancer with the mode of delivery?
No, as far as I know, there is no relationship between cesarean section and breast
Yes,
cancer
sir.
development.
Thank you, sir.
No,
Sir,
but there's some
sir,
relationship with hormonal treatment. If somebody is on oral contraceptive pills for more than 10 years, or if it's on HRT or hormone replacement therapy for more than 10 years, or some intrauterine device like Marina coil and other things, that can have some effect, but not cesarean section.
Sir, second question, sir. If there is a definite lump, so why not first the core biopsy? Why at first imaging?
If there's a definite lump, you should always do a core biopsy in the first imaging. Yes, irrespective of what kind of lump is that. Is a benign lump like fibroadenoma or even a fibrocystic disease, it has to be confirmed by core biopsy. You're absolutely right. Then
but
you
if
can
it is if it is seems to be clinically malignant, if it is clinically malignant, like
yes,
যেটা আমার মনে হলো যে তুমি কি বলতে চাও যে ইমেজিংটা আগে করবে নাকি বায়োপসি আগে করবে, মানে কোশ্চেনটা কি তোমার?
সরি,
কোয়েশ্চন স্যার যে স্যার আপনাদের ওই যে প্রেজেন্ট তাকে প্রশ্ন করছিলেন যে এখন তুমি কি বলছো, সে বলছে যে আগে ম্যামোগ্রাফি করবো, যেখানে স্যার তার প্রেজেন্টেশন হচ্ছে ডেফিনেট লাম্প আছে, তো সেই ক্ষেত্রে কোর বায়োপসি আগে না করে কেন আমি ইমেজিং এ যাবো?
Oh,
Imaging
that's a good question actually.
মানে
আমি
কারণে
এটা বুঝতে পারি।
কোর বায়োপসি করলে তোমাকে যে আর্কিটেকচারাল ডিস্টরশন হবে দ্যাট উইল তোমার পরবর্তীতে ওটাকে রিড করতে বা ইন্টারপ্রেট করতে একটু মিস ইন্টারপ্রিটেশন হতে পারে। সো
Right, sir.
issue should have this imaging first, then core biopsy should be undertaken. What do you
আচ্ছা স্যার, এখন যদি কোর বায়োপসি যদি অ্যাভেলেবল না থাকে তাহলে কি আমরা এফএনসি করতে পারবো, না কোর বায়োপসির জন্য আমরা যেখানে কোর বায়োপসি অ্যাভেলেবল সেখানে পাঠাই দিব?
যেখানে অ্যাভেলেবল সেখানে পাঠিয়ে দেওয়া মানে উইল রিকমেন্ড, কারণ হচ্ছে ইফ ইউ ডু অ্যান এফএনসি দ্যাট উইল সিম্পলি মানে জাস্ট তোমাকে একটা ট্রাপে ফেলে দিবে। হ্যাঁ, এবং এই ট্রাপ থেকে বেরিয়ে না এসে তোমার থেকে পেশেন্ট আর একখানে গেল, ওটা দেখলো, সেটা দেখে কোন একজন ওইটাকে অপারেশন করলো সাবসিকুয়েন্টলি। একটা এরর থেকে বা একটা ভুল পথ থেকে কিন্তু ভুল পথেই যায় মানুষ, অতএব ওই ভুল পথ থেকে একেবারেই না যাওয়া।
রাইট স্যার। স্যার আরেকটা কোয়েশ্চেন, যদিও এটা স্যার আমাদের কেসের সম্পর্ক না, কোর বায়োপসিটা কে করবে স্যার, প্যাথোলজিস্ট না সার্জন স্যার?
বোথ
both can perform this.
প্যাথোলজিস্ট, সার্জন এন্ড দ্য রেডিওলজিস্ট। আমাদের এখানে আজকে আছেন যে প্যাথোলজিস্ট আছেন, এখানে রেডিওলজিস্ট আছেন ডক্টর শামীম আক্তার রুবা, উনি খুব এক্সপার্ট।
আমি রেডিওলজিস্ট আছি স্যার, মাস্ট বি ডান বাই দ্য রেডিওলজিস্ট।
খুব এক্সপার্টলি করেন, হ্যাঁ, অতএব করতে পারেন। ওকে
স্যার আরেকটু সময় নিব স্যার, আরেকটা কোয়েশ্চন ছিল স্যার।
শিওর।
আর ওই যে ট্রিটমেন্টের ক্ষেত্রে স্যার এখানে কামাল স্যার বললেন যে নিউঅ্যাডজুভেন্ট কেমোথেরাপি দিতে হবে, আর জাকিরুল স্যার এক সময় বলছেন যে ইফ ইট ইজ অপারেবল এন্ড ইফ ইট ইজ মানে ইন্টারভেনশনেবল দেন ফার্স্ট রিমুভ দ্য টিউমার বিফোর নিউঅ্যাডজুভেন্ট কেমোথেরাপি। During examination, which answer we shall correct? Is it for the downstaging only the neoadjuvant chemotherapy is appropriate, or in all cases neoadjuvant chemotherapy is appropriate?
কাজে আমি বোধহয় একটু কনফিউজ করে দিয়েছে তোমাকে। আমি কিন্তু ওকে অন্য কথা বলেছিলাম, সেটা ER পজিটিভ ক্যান্সার and PR positive and HER2 negative cancer. এই পেশেন্টের ব্যাপারে বলি নাই। এই পেশেন্ট ট্রিপল নেগেটিভ ক্যান্সার ইজ অলওয়েজ দে শুড হ্যাভ নিওঅ্যাডজুভেন্ট কেমোথেরাপি। সো মাই অ্যাপোলজি যদি আমি তোমাকে কনফিউজ করে থাকি, আই এম রিয়েলি সরি। আসলে সত্যি কথা বলতে আমি একটু ওকে ডাইভার্ট করছিলাম, যেহেতু ও খুব ভালো অ্যান্সার দিচ্ছিল। So just to see whether she has got that idea, but just remember, and তোমার কোয়েশ্চেন গুলো সব সুন্দর, কিন্তু বিউটিফুল কোয়েশ্চেন তুমি করেছো। Please remember, we want to help patients. So don't do anything which is not helping patients. By doing final needle aspiration cytology, you are not helping the patient at all. Have the proper treatment for proper patient, just like the way you will treat your mother or your sister. Send them to a center where they'll be able to do that core biopsy. Okay, thank you.
Thank you, sir. You are not confusing, sir, but it is for our just shallow knowledge, sir.
Okay, sir.
It is for our shallow knowledge. You are not confusing, sir. You are clear.
Sure.
So our knowledge is very much shallow. Thank you, sir. Thank you, sir.
Dr. Kamal, please.
So regarding the core biopsy, I want to say that anybody can do, but it is the domain of interventional radiologist. So it can be done by anybody, but if you ask me what is the ideal domain, it should be by interventional radiologist. That was my comment.
I completely agree, because the reason is sometimes the lump you're feeling might not be the tumor. It might be completely benign thing. So you need some imaging to see whether there's something hiding behind. Second thing is, a lump can have a periphery of completely connective tissue. You are probably doing blind biopsy, which will come as conclusive as benign thing, which will confuse the whole thing. It happened before. So always it should be done by the interventional radiologist.
Dr. Thank you.